All right. Well, thank you very much, everybody, for joining us today. Good evening. I'm Ronston Lobo, and I'm a clinician investigator and fellow in cardiovascular diseases at the Mayo Clinic in Rochester, Minnesota. So this evening, I have this distinct opportunity to speaking to you about coronary artery anomalies. And I intend to approach this by discussing some cases. So let's get started. So some learning objectives. Upon conclusion of this activity, you should be able to recognize the two main coronary anomalous aortic origins, risk stratify patients with these specific coronary anomalies, and differentiate which patients need repair. I wish I had disclosures, but I do not. So let's start with some cases. So the first case, so we have a 56-year-old female with chest pain, has a history of congenital pulmonic stenosis, had a surgical valvotomy in 1973, and a history of hypertension and type 2 diabetes mellitus. With the chest pain, she had a stress echocardiogram done. This was negative. A CTA was done, and this showed an anomalous origin of the right coronary artery from the left sinus with an interarterial course. So here's the CT with the red arrow pointing to the anomalous coronary artery. What further investigations should be done, and what treatment, if any, should be offered? Case number 2, a 62-year-old man with chest pain, history of paroxysmal atrial fibrillation, hypertension, and a current smoker. Stress echocardiogram was done, did not show any evidence of regional wall motion abnormality. However, the ECG showed some ST depression in multiple leads. Again, a CTA was done and showed an anomalous origin of the right coronary artery coming from the left sinus with an interarterial course and a segmental intramural course in the aortic root. Here's the CT, the red arrow again pointing to an anomalous coronary artery. What further investigation should be done, and what treatment, if any, should be offered? And finally, the third case, 47-year-old man with chest pain, history of Crohn's disease on medical therapy that is well controlled. With his chest pain, he had an exercise technetium 99 sestamibi scan, no perfusion abnormalities, had excellent exercise capacity, 12.5 METs, and a normal LVEF of 67%. CTA showed an anomalous origin of the left coronary artery from the right sinus with an interarterial course and a segmental intramural course in the aortic root. Once again, here's the CT with the red arrow pointing to the anomalous artery, and you can see it's between the pulmonary artery and the aorta. Again, what further investigation should be done, and what treatment, if any, should be offered? So please consider these cases, and we will come back to them later to discuss the outcomes of each case. Now, before we get started, though, let's gauge the current knowledge level of the audience with some pre-presentation questions. I'm going to do a set here, and then at the end of the presentation, we're going to do the same questions again to gauge if there's any change in knowledge level. So question 1. In the absence of symptoms, surgery is not indicated in patients with anomalous aortic origin of the left coronary artery from the right sinus. Is this true or is this false? So I'm going to launch the questionnaire right here. Please go ahead and answer them. Okay, I'm going to end the poll here. And here are the results. So it's kind of an even split, 40-60. So let's move on to question number 2. Of the high-risk anatomic features used to stratify risk in anomalous left coronary arteries, an interarterial course is the most important. Is this true or is this false? I'm going to launch the question right here. Please go ahead and answer it. Okay, I'm going to end the poll here. So this time a much more bigger split, and with most of you stating that this is true. All right, I'm going to share the results as you can see over here for everybody. It's 73% true and about 27% false. All right, let's move forward. So coronary anomalies. Coronary anomalies are a group of congenital conditions characterized by abnormal origin or cause of any of the three epicardial coronary arteries. It has been identified as a common underlying condition in young athletes with sudden cardiac death. However, with the widespread use of invasive and non-invasive coronary imaging, this has led to an increased recognition of coronary anomalies among adults, especially older adults. And this is often found incidentally. When we classify anomalous coronary arteries, we can classify them into four categories. There's anomalies of the origin and course, for example, a right coronary artery arising from the left coronary sinus, as shown in our previous two cases earlier. We can classify them according to the intrinsic coronary anatomy, for example, coronary ectasia or aneurysms. We can also classify them according to their termination, for example, fistulas into the atria or ventricles, and there's also anomalous anastomotic vessels. Now, if you want a comprehensive review of this topic, this book by Paolo Angelini, who's based in Texas, will provide it to you. This book is 200 pages long, and that's just coronary anomalies. I pulled out one of the first tables here on the different types of coronary anomalies. And as you can see, this table goes on and on and on. And here's the best part. There's actually another part of this table. I just showed you the first half of it. So what I'm trying to say is that this is a pretty complicated field. We are only going to be scratching the surface here, focusing on a couple of very specific anomalies. We are going to focus on just anomalous aortic origin of the right and left coronary arteries from the opposite sinus. It is the more frequent, and unlike many other coronary anomalies which have a benign course and outcome, these group of anomalies may have more malignant outcomes. Some definitions to get out of the way. So when I refer to AAOCA, I'm referring to anomalous aortic origin of the coronary arteries. AAOLCA is the anomalous aortic origin of the left coronary artery. And AAORCA is anomalous aortic origin of the right coronary artery. So why do we need to concern ourselves about this? I mean, the prevalence is only about 1%. However, autopsy series have shown that after hypertrophic cardiomyopathy, coronary artery anomalies are the second most common cause of sports-related sudden cardiac death in young athletes. And in one study, about 1/3 of sudden cardiac death in military recruits in the United States was attributed to anomalous coronary arteries. However, these data are in a very selected population, mostly of young patients that are involved in activities with significant physical exertion. Some reports have suggested that the risk of sudden cardiac death is overestimated because of reporting biases as well. A more accurate representation of the risk of sudden cardiac death has been hampered by the lack of mandatory reporting of sudden death in most countries, and autopsies are not done universally in all cases of sudden cardiac death. The question we have to ask ourselves is, does this concern of sudden cardiac death that is seen in this very selected population apply in the same way to, say, a middle-aged or older individual diagnosed incidentally on CT imaging? Natural history studies are also lacking. How many asymptomatic patients have coronary anomalies? Apparently, healthy individuals walking the streets of your town have coronary anomalies. The long-term outcome data is also lacking. If I have a coronary artery anomaly and I'm healthy and have not had any symptoms, will I survive longer if I have surgery versus not having surgery? And the guideline recommendation is actually limited by this lack of data in these settings, but we can expect, and as I'll show it to you when we look at the guidelines, you'll see how the data is limited and how their recommendations are thus also hampered by this. But this was expected to change as more data is being gathered going forward with the amount of CTs that we're doing nowadays in a bunch of older individuals and mid-aged individuals who are not in active sports. I think more data will be gathered and we'll be able to come up with further recommendations. Now, let's touch on the factors that may relate to sudden cardiac death in patients with AAOCA, because they're the foundation of which the management guidelines are built upon. AAOCA is more commonly invoked as a cause of sudden cardiac death in patients less than 35 years of age. After 35 years of age, atherosclerotic CAD becomes more prevalent. High-risk anatomical features have been proposed as a reason for sudden cardiac death. The more common high-risk features described in the literature are listed below. I place a question mark on interarterial cause because there are now questions being asked as to whether this is truly a high-risk feature. I also highlighted intramural cause in red, as that is the only one with a consistent possibility of causing coronary dysfunction from stenosis. AAO-LCA is less common than AAO-RCA, but it's often found more in autopsy series of sudden cardiac death, either due to AAO-LCA being more prone to coronary compromise or because of the larger proportion of myocardium supply, or both. In other words, AAO-LCA carries a higher risk of death than AAO-RCA. Autopsies series have suggested that most patients die during or in close temporal association with exercise. The series have also demonstrated myocardial fibrosis in a significant number of patients whose deaths were attributed to AAO-CA, suggesting ischemia plays a role. However, other data indicate that a normal stress test does not preclude SCD or sudden cardiac death. And in fact, it is often the case that stress testing is negative. This will come to play in the guidelines, which I will get into later. Symptoms have also been associated with risk of sudden cardiac death. These are more commonly reported in AAO-LCA, and surgical series have described improvement in symptoms after surgical repair. Symptoms will play a big role in delineating which patients will need surgical repair, as we will see later. So based on these factors that relate to sudden cardiac death in patients with AAO-CA, when we are assessing these patients, we need to ask 4 questions to risk stratify them. Number 1, is it a right or left anomalous coronary artery? Number 2, is the patient symptomatic? Number 3, is there evidence of ischemia? And number 4, are there any high-risk anatomical features? The steps that we take to determine the risk: we take a history. Number 2, we do an anatomic evaluation. And number 3, a physiologic and functional evaluation looking for ischemia. Now, when it comes to anatomic evaluations, CT angiography is the primary investigation of choice. It is rapid, has high spatial resolution, and has the ability to detect anatomic high-risk features. Cardiac MRI has been playing an increasing role, though. It has high spatial resolution, although not as high as a CTA. And in addition to that, it can obtain additional valuable information, such as valvular function, ventricular function, regional contractility, late gadolinium enhancement, suggesting scarring, and even look at myocardial viability. However, it does require centers with expertise and thus does not have as high a diagnostic consistency across imaging centers as CTA does. In the pediatric population, though, the preference is to use cardiac MRI, again, because of the lack of ionizing radiation. So now let's look into the high-risk anatomic features. Now, in order to describe an interarterial course, which is the first one we're going to talk about, let's first look at the normal course of the coronary arteries. So what you see here is the left coronary artery coming off the left aortic sinus. I pointed my mouse here, and it crosses between the 2 great arteries, on the left coronary artery, and the right comes off the right coronary cusp right here. Now, this is the normal anatomy, okay, anterior posterior, as you can see here. Now, firstly, I'm going to show you an interarterial course. So in an interarterial course, the anomalous artery comes off the opposite cusp and crosses between the 2 great arteries, hence the term interarterial. There are also other variations, such as pre-pulmonic, where the anomalous coronary artery goes in front of the pulmonary artery. There's retroaortic, where the anomalous artery goes behind the aorta. These are considered to be more benign anomalies. There's also subpulmonic, also known as intraseptal. This is where the anomalous artery crosses between the aorta, the RVOT, and the pulmonary infundibulum, i.e., it is below the pulmonary valve. This is also considered a benign course. I should note that all these pictures show an anomalous left coronary artery, but these distributions can also be seen with an anomalous right coronary artery. Now, why is an interarterial cause thought to be high risk? Well, because there's a concern that the compression between the great vessels as shown here. As shown in this, in this figure, the anomalous artery is between the aorta and pulmonary artery, and during systole, there's expansion of both the aorta and pulmonary artery as a result of increased flow, and this can result in compression, particularly during exercise, where the diameter of the aorta and pulmonary artery can increase significantly due to increased pressure and volume. However, as I mentioned, there's questions being raised about this now as to whether this is an actual phenomenon that occurs and whether it's as high risk as we thought initially. And I will come back to this later. A slit-like orifice. So a slit-like orifice is a greater than 50% or greater reduction in the minimal lumen diameter of the orifice compared to the normal distance reference diameter. So this is a CT image showing the luminal diameter of an anomalous coronary artery measured over the ostium in A and over the distal segment in B. As you can see, there's a greater than 50% reduction in the size of the ostial opening of the anomalous coronary artery. This is thought to result in a limitation of coronary blood flow. An acute angle takeoff is where the angle between the proximal coronary artery and the aortic wall is less than or equal to 45 degrees. So coming back to the image we discussed earlier, you can see that with the normal coronary artery here, the angle of takeoff here is almost 90 degrees. But if I take the interarterial cause, for example, the angle here is almost, it's coming off to less than 45 degrees. This is thought to increase the risk of compression of the vessel as the aorta expands during physical activity. A high takeoff. A high takeoff is a coronary ostium that comes off 1 centimeter or above the sinotubular junction. Here's a cartoon figure of the aorta splayed out, and as you can see, there's the high takeoff of the coronaries up here. A high origin of the ostia may reduce diastolic coronary artery blood flow and thus increase the risk of ischemia. An intramural course. So this is a CT image showing an example of anomalous right coronary artery coming off the left sinus and taking an intramural course. The left main coronary artery is shown in the white arrow, and as you can see, the anomalous right is that's the one labeled with the star. The red line here represents the lumen of the aorta, and the blue line represents the approximation of the aortic wall. You can see that the anomalous artery has a course within the aortic wall, and this results in a fixed stenosis. Not only that, there's also a dynamic component with the aorta expansive pulsation that worsens compression of the lumen, and this is especially so during exercise. This, combined with the decreased diastolic time during exercise, which also reduces coronary blood flow, is thought to contribute to ischemia. So that's anatomic evaluation. Now we come to a physiologic evaluation. For physiologic evaluation, there are two approaches. Number one is using the non-invasive approach, using a stress echocardiogram, nuclear perfusion imaging, or MR stress perfusion imaging. Invasive options of stress testing involve intravascular ultrasound and using intracoronary ultrasound imaging. You can also use FFR or IFR, which are intracoronary pressure measurements. Now, when it comes to guideline recommendations, there are 3 societies that have proposed guidelines for evaluation and management of these conditions. There's the American Association of Thoracic Surgery, the American Heart Association and ACC, American College of Cardiology, and the European Society of Cardiology. The ASC guidelines are the most up-to-date. They were published in 2020. Now, I pulled this table from a paper published in June last year because I think it summarizes the guideline recommendations quite well. You can see the guidelines differentiate between an AAO-LCA and AAO-RCA by separating them into their own tables here. As we know, AAO-LCA carries a high risk of an adverse outcome. Now, I'm going to talk here about management of patients with symptoms, okay? So you can see here that symptoms play a big role, as I mentioned earlier, because if you have symptoms, it is pretty clear. For AAO-LCA or AAO-RCA, the recommendation is for surgery, regardless of whether there's evidence of ischemia or whether there's a high-risk lesion. The Europeans, however, did carve out a small caveat here, as you can see, in patients with no ischemia and no high-risk anatomy, where they say surgery may be considered, but it's not a full class 1 recommendation. Now, what if you have no symptoms? So this is where the data is somewhat lacking in different parts of it, and I'll go through for it in a second. So I'll be graying out the non-relevant parts of this table. Recall I mentioned earlier that the data in the literature have indicated that a normal stress test does not preclude the risk of sudden cardiac death. And in fact, it's often seen that stress testing is negative. So if you have a positive stress test, you would strongly want to consider surgery, whether there's a high risk lesion or not. And most of them kind of recommend moving in that direction. The data is lacking, of course, in patients with no symptoms and no ischemia. Now, what is important to know with AAO-LCA is that even if you have no symptoms, no high-risk lesion, no ischemia, surgery can still be considered. The Europeans have coned it down further, though. They have said that you can consider surgery, especially if they're under 35 years of age. Recall, age is also a factor in sudden cardiac death. Now look at the same group for AAO-RCA. While the HA and ACC and also the AATS have some recommendations for surgery, or even you could observe if you need, the Europeans have given a clear no to this. They say if you have no ischemia, no high-risk lesion, and it's a right AO-RCA, you should really not consider surgery. We don't have enough data in patients with no symptoms, no ischemia, and have high-risk features. So to summarize the differences between the AHA and ESC guidelines, the ESC guidelines are less aggressive. For example, they do not outright recommend surgery in AAO-LCA without symptoms, ischemia, high-risk anatomy, unless they're less than 35 years of age. They also do not recommend repairing an AAO-RCA without symptoms, ischemia, or high-risk anatomy. It is interesting to note, though, what the ESC defines as high-risk anatomy. So here's the recommendation for AAO-RCA without symptoms, ischemia, or high-risk anatomy that I pulled from the guidelines. You can see that they define high-risk anatomy as intramural cause, slit-like orifice, acute angle takeoff, and orifice above 1 centimeter, like we previously discussed. Conspicuously missing from here, though, is an interarterial course. In fact, they do talk about it in the guidelines, and they highlight that there's debate about the ongoing management of AAOCA, especially in patients with an interarterial course. Now, could interarterial subtypes play a role here? For example, here's a paper that was published years ago describing 2 subtypes of right coronary artery anomalies arising from the left coronary artery, left coronary sinus with an interarterial course. They noted that patients with a high interarterial course, in other words, where the ostium arises above the pulmonary valve, would be a higher risk subtype because it is more likely to get compressed between the aorta and the pulmonary artery, both of which distend during systole. However, in a low interarterial course, where the ostium comes below the pulmonary valve or subpulmonic, as we talked about earlier, they have a lower risk of being compressed because it arises between the RVOT and the aorta. And the RVOT contracts during systole. Therefore, the risk of compression is much lower. There are also others who don't actually think this compression phenomenon between the aorta and pulmonary artery is actually a cause of mortality. They think that their patients with interarterial course may have coronary hypoplasia associated of the proximal segment of the ectopic artery near the aortic wall. And in those patients who have that hypoplasia, that's where the risk is higher. So in addition to the 3 steps to determine risk, there are also very important shared decision-making processes that have to be considered. Some of these patients are very anxious about their condition. Some of them have been told or they have read online, on websites or forums that they have a ticking time bomb in their chest. And if it's not fixed, they're going to drop dead. Therefore, they're rightly scared and want something done. Some are limited because of their condition. For example, you could have a patient, for example, who travels often and is worried that, what if I travel to a different state in the middle of nowhere and then I suddenly get chest pain? Well, what do I do then? I have nowhere to go and I don't know what hospital I'm going to go to and what they're going to do about it. Some patients also participate in competitive sports. So if their physician is going to limit their physical activity, or the patients themselves are going to limit their physical activity because of fear of what might happen to them, then it might be reasonable to consider operating, especially if their risk cannot be clearly defined by the guidelines. So let's go back to the cases now and discuss them after going through this initial aspect of the knowledge acquisition. So regards to the first case, 56-year-old chest pain we talked about, congenital pulmonary stenosis, history of hypertension, type 2 diabetes. Stress echo, remember, was negative for ischemia. The CTA showed anomalous aortic origin of the right coronary artery from the left sinus with an interarterial cause. Delving into the chest pain history, the patient says the chest pain is preceded by stress. It's a sharp pain that resolves quickly and is worsened when they place the ultrasound probe while doing the echo. She had an MRI cardiac rest and stress without IV contrast, and we'll go through them in a second. So let's show you the CT images first. Panel A here shows an axial slice with the aorta and pulmonary artery labeled. The white arrow represents the left main coronary artery coming off the left sinus, and the red arrow shows the anomalous right coronary artery coming off the left sinus. Panel B shows a sagittal slice, and you can see with the red arrow of the anomalous right coronary artery coming up the left side of the aorta and courses between the aorta and the pulmonary artery. The MRI cardiac stress test that was ordered, this is a first pass perfusion. Images are taken in short axis, so equivalent to the parasternal short axis that is done on echo. The images are from your left to your right, representing the base, mid, and apical aspects of the left ventricle, respectively. There was no perfusion defects noted at rest or at stress. So to summarize, this patient had atypical chest pain. Coronary anomaly was noted with an interarterial cause, but no other high-risk features. Ischemia testing was negative. They discussed this in a multidisciplinary conference, and it was felt that the symptoms were unlikely related to the coronary artery anomaly. Therefore, no surgery was recommended. The patient was reassured. Case number 2, coming back to the 62-year-old man with chest pain. Stress echocardiogram showed no evidence of regional wall motion abnormality. However, there was this ECG changes with some ST depression in multiple leads. The CTA showed the anomalous origin of the right coronary artery from the left with an interarterial cause, just like our first case, but also a segmental intramural cause in the aortic root. When you take the chest pain history, this patient has been complaining of central chest and left arm discomfort, associated dyspnea, brought on by exertion, relief by rest. So a lot more typical sounding. CT images here. So panel A shows the axial slice with the aorta and pulmonary artery label. The white arrow shows the left main coronary artery coming off the left sinus, and the red arrow shows the anomalous right coronary artery coming off the left sinus. Panel B is a curved planar reformatted image showing the anomalous coronary artery coming off the left sinus. And you can see there's a significant stenosis at the proximal segment of the artery as I'm pointing with my mouse right here. Panel C shows a sagittal slice, and you can see with the red arrow the anomalous right coronary artery coming off the left side of the aorta and courses between the aorta and pulmonary artery. This CT was sent for FFR CT analysis. You can see the results here showing a significant reduction in values in the anomalous coronary artery as pointed here. FFR has been established in the physiologic evaluation of coronary artery anomalies. FFR CT is relatively new to this field. However, there are initial studies showing added prognostic benefit in determining ischemia in patients with coronary artery anomalies. This is a developing field. So to summarize this case, cardiac sounding chest pain, coronary anomaly noted with an interarterial cause and intramural segment with severe stenosis and diastole. Ischemia testing was partially positive with a positive ECG, although negative wall motion abnormality. They discussed this in a multidisciplinary conference. This patient was considered to be high risk and therefore was offered coronary unroofing surgery. So let's talk about coronary artery roofing for a second. So here's a figure. This is the most commonly performed procedure for this condition. Here's the figure showing you an anomalous right coronary artery coming off the left sinus with an intramural course. You can see here there's a roof over the intramural channel as shown here, okay? and I pointed out in red. What the surgeon does is incise this roof open and then essentially incorporate the intramural channel into the aortic lumen. So by removing this roof, the site of the coronary exits of the aorta is now the new ostium, and you've incorporated an intramural channel into the actual aortic lumen. So now I'm going to show you the intraoperative images from this case, but in order to do that, I'm first going to try orientating you first by superimposing the CT image on the intraoperative image. It's a bit hard. It's a 2D picture on a 3D structure. But first, what I'm going to do is to flip this image horizontally. So now you see the surgeon's view looking from the head down, as opposed to the CT view where you're looking from the leg up. So I'm gonna flip the image here horizontally. Now I'm going to show it to you here. This is the intramural segment again. Now the left main ostium is now on your left side of your screen. Superimposing this on the CT image here now. And now I'm going to remove the CT. You can see here that this is the aortotomy that has been performed. They're beginning to unroof the intramural segment on this picture. And here's the label of the other structures that are associated. The head is on the left, the feet is on the right. So now here it is completed. What you can see is that the previous ostium of the RCA corresponding to the figure here has now been opened, and the previous lumen of the intramural segment is now part of the lumen of the aorta that I'm showing over with my mouse here. Now, I don't know about you, but the thing that stuck out to me the most when I saw this picture were these stitches. And Dr. Joseph Deraney, who actually did the surgery here at Mayo, um, when I asked him about this, what he said was these are the stitches to tack the intima to the wall of the aorta. And this is done to prevent dissection of the intima. So now let's look at the CT images post-surgery. So now panel A shows an axial slice with the aorta and pulmonary artery label. The red arrow now shows the right coronary artery coming off the right sinus. And panel B is a curved planar reformatted image similar to the one earlier. The white arrow now shows the left main coronary artery coming off the left sinus. And the red arrow now shows the right coronary artery coming off the right sinus, as it should be. Now, what about case number 3, 47-year-old man with chest pain, Crohn's disease on medical therapy. Exercise study showed myocardial perfusion imaging had no perfusion abnormalities. Excellent exercise capacity. But the CT showed an anomalous left coronary artery from the right sinus with an interarterial course and an intramural course as well. His chest pain history, well, he actually had atypical chest pain, not associated with activity, had some dizziness on exertion, and when we asked him about his chest pain during the stress test, he did not have any. So I'm going to show you the CT images again. So this is panel A showing an axial slice of the aorta and pulmonary artery label. The white arrow shows the right coronary artery coming off the right sinus, and the red arrow shows the anomalous left coronary artery coming off the right sinus. And it's taking an interarterial, but more importantly, an intramural course. And panel B shows curved planar reformatted image showing the anomalous left coronary artery coming off the right sinus and taking an interarterial course, subsequently branching off to the LAD and left circumflex arteries. So in summary, atypical chest pain, but it's a left coronary anomaly with an interarterial course and an intramural segment. And even though ischemic testing was negative and this guy's symptoms were atypical, it was considered to be high risk. As we discussed earlier, it's an anomalous left coronary artery system and as an intramural course. So this patient was considered to be high risk and thus offered unroofing surgery. I'm going to show you the images again. First, I'm going to try and orientate you. So I'm going to flip this image again. Now you're seeing the surgeon's perspective. And now I'm going to just try and put it in the right orientation for the surgery. You can see this is now the RCA ostium coming on the right side of your screen and that intramural segment over here. So now if I superimpose the image, and now I'm going to remove the CT image here, you can see that this is the RCA ostium is sitting behind this retractor. This is the intramural segment that they've opened up. They're attacking the endothelium, as you can see here. And this end over here is where the LM's left main coronary artery neo-ostium is. So now let's look at the CT images post-surgery. So panel A shows a 3D reconstruction of the CT images with the aorta label. The white arrow shows the right coronary artery coming off the right sinus, and the red arrow over here, as you can see, shows the anomalous left coronary artery coming off the right sinus. Now, panel B shows the same 3D reconstruction, but it's post-repair. So the white arrow shows the anomalous, showing the right coronary artery coming off the right sinus, and the red arrow now shows the left coronary artery coming off the left sinus, as it should. So I had the privilege of speaking with Dr. Joseph Duraney, who operated on both of these patients. He's not only one of our most experienced surgeons here at Mayo with coronary artery anomalies, he's one of the primary authors of the ACC-AHA congenital heart disease guidelines. Unfortunately, he could not join us here today, but he did provide me with his perspective, which I would like to share. So from his perspective, unroofing is the procedure of choice. If the patient has an AAO LCA and if they're young, he would offer unroofing. If they were older, he would rule out concurrent coronary artery disease first, because if there's distal coronary artery disease of that vessel, instead of performing unroofing, you could just do a cabbage. For an AORCA, he would unroof if there's a positive stress test, if the patient has symptoms consistent with ischemia, because remember, as I said, stress test is often normal in many cases. Or if the cardiologist or patient has plans to restrict the activity and thus limit the patient's lifestyle choices. He obtains a TEE during the surgery to ensure the neo-orifice blood flow is not turbulent. And more importantly, he always obtains a CT of the coronaries prior to discharge. This is to ensure that there's completion of the unroofing. It's also to ensure that there's no other complications such as dissection. And it also provides a new baseline image. So comparisons can be made if something were to happen in the future. So we've covered a lot today this evening. So let's summarize. AAOCA, second most common cause of sports-related sudden death in young athletes. Natural history studies are lacking. Long-term data in middle and older age individuals with incidental AAOCA is lacking. Intramural cause is considered to be the most significant high-risk anatomic feature. Management depends on a few factors: which anomalous coronary artery is it, presence of symptoms, evidence of ischemia, and the presence of high-risk anatomy. AAO-LCA is a higher risk than AAO-RCA. AAO-LCA can be repaired even if there's no symptoms, ischemia, or high-risk anatomy, especially in ages under 35 years. I'll just caveat this by saying that there's a lot here that's not been covered. This is just a very brief overview. It is very important that in these patients, a multidisciplinary strategy is initiated with experts participating from surgery, congenital heart disease, and imaging. I'd like to acknowledge the Mayo Clinic experts that helped me in this presentation: Dr. Luke Burchill of the Adult Congenital Disease Service, Dr. Christopher Francois of Radiology, and as I mentioned earlier, Dr. Joseph Duraney of the CV Surgery Service here at Mayo Clinic. So before we end, we're going to do the post-presentation questions. So it's the very same question again. In the absence of symptoms, surgery is not indicated in patients with anomalous aortic origin of the left coronary artery from the right sinus. Is this true or is this false? Please go ahead and answer. Okay, I'm going to end the poll here. And yes, you're all right here. It is definitely false. So as mentioned earlier, if you have an anomalous left coronary artery, whether you have symptoms or you don't, whether you have high-risk features or not, or whether you have ischemia, you can consider surgery in these patient groups. So question 2 now again. Of the high-risk anatomic features used to stratify risk in anomalous left coronary arteries, and interarterial course is the most important. Is this true or is this false? Okay, I'm going to end up, we'll share the results here. So it's still a 50-50. So again, to highlight, the reason this is false is because an interarterial course is not the most important risk factor. There's a lot of debate going about it in the guidelines. And in fact, as I mentioned in the 2020 guidelines, it is not mentioned as a high-risk anatomic feature, at least according to the ESC. And even in the discussions here, the intramural course is considered the most high-risk feature. And this is endorsed by multiple publications. Show it over there. So, all right, so we'll show a comparison of the results here in just a second. But in the meantime, I would like to say thank you very much for participating today, and thank you for joining me. And I'm happy to answer any questions that you might have. Thank you.
Don't be shy if you have questions. Please use the Q&A box to submit those. And I have a little comparison here so you can see the difference between the pre-talk questions and the post-talk questions. So here we are on question 1. I'd say that's pretty successful.
I agree.
And here we are on question 2.
There's some change, but it still appears to be a 50-50 in the second question. And yes, as mentioned, this is where the trends currently sit with the guidelines, and this is based on the literature data that we've been having. Now, again, as we get more data, especially so in the older population, middle age, older adults, this is something that potentially can change, but it's being increasingly questioned, this whole interarterial course. So let's see here. We have some couple of questions. So the first question here is CCTA sensitive enough to pick up coronary hypoplasia of the ostium? Is this something you should be looking for? Yes, if you do proper CT coronary imaging, yes, you can pick up hypoplasia at the ostial level. It has to be a properly gated CT coronary angiogram, though, to pick up these things. If they have fast heart rates and not adequately rate controlled, you're going to get a lot of blurriness in your imaging, and you may not pick it up. So yes, CCTA can pick this up. There's another question over here. Is there a different approach if there's an anomalous left coronary artery as opposed to anomalous, if there's an anomalous left circumflex as opposed to anomalous left coronary artery? That's a really good question. So again, I provided a broad overview of the right and the left. Now you may have branches. Sometimes you may have an anomalous LAD only, or an anomalous circumflex only, which is actually quite common, just an anomalous circumflex. That really depends. It is not as clear as to what to do with these. But again, I specifically asked Dr. Durrani about this because we see this quite often. And his approach, at least, is to look and see, can you tie the patient's symptoms that they have? Is this ischemia? Is there evidence of ischemia on testing? Is there symptoms consistent with cardiac ischemia? Is there evidence of stress perfusion imaging? And MRI stress perfusion imaging is increasingly being used now because, again, you can look for things not just for myocardial perfusion abnormalities, but evidence of scarring. And if you can find that in that region of the left circumflex, then you have a better argument to say that you need to do surgery. So that's a good question, and the answer to that question is it depends. And having a multidisciplinary discussion is really important with these. It's not clear cut at all that one you should operate on and one you shouldn't, especially when it regards to branches of coronary arteries as opposed to the whole coronary artery. Very good questions. So can you comment on one question? Can you comment on stenting coronary anomalies? So I'm not sure how you would go about that. So if you have an anomalous origin and there's a narrowing, you want to stent it open. I mean, you could, but the problem is that if there's extrinsic compression on these, sometimes your stents won't be of value to you. But it's a good question. I actually not seen that. I mean, the some of the cases we have seen is sometimes where there's an anomalous origin and they instead of stenting the vessel open, they actually occlude it and do a cabbage instead. I've seen that in some cases in Europe. I've not seen it in the States yet though. But what they do is that they do a cabbage instead of unroofing and all that, which is a more intensive and more um, complicated procedure. They do a coronary artery bypass, then they occlude the native vessel. But again, not seen it in the United States yet.